Hello, hello. Hi, Stephanie. How are you today?
I'm doing well. Happy New Year.
Happy New Year. Chris, how are you? It's New Year's. It's crazy. It's January 3rd.
I know it is insane. It's like, it's that thing where every time you go to write something, you keep doing the 2023 and then you have to cross it out and then put like 2024 and it's like, oh great, it's began. But I'm excited for the new year. I'm
Yeah.
excited.
I'm wondering how many things you handwrite because I feel like I don't handwrite anymore. In school, I used to deal with that, but like, what are you handwriting, Chris?
You know what? I started with a new intensive outpatient client and I always like to handwrite like some stuff on the first day and then type it up. And so, just jotting all the new information and I kept like writing notes by hand and kept crossing out the 2023.
Okay,
So
that's fair.
I wrote I wrote I wrote a check yesterday and I got 24 on the first try. So I
There you
was
go.
very
ah,
proud of myself.
you're
Send it.
definitely beating me.
That will come up. Love it. So good to see you all. Hi, everyone. Thank you for joining. We are so excited to have you guys here. I feel like it's been a while. I know last week we were off with the Christmas holiday, so I'm just really excited to be back. I cannot believe it's 2024. And so, of course, today, nobody will get to log off without setting some goals and intentions towards OCD treatment for 2024. So we will definitely end with that. We're going to do things a little bit different going into the new year. So, of course, we're going to introduce our guest, Stephanie, in just a second and our topic and what we're going to cover. But what we want to do is we want to make sure we get to questions. We have found that Chris and I and our guests, we get so excited and there's so much content that we don't always get to dedicated time for Q&A. And so what we're going to commit to is that we are going to be doing a topic like we will today. And then at about the 30 to 40 minute mark, we are going to hop into live Q&A where we're going to do just questions. And Stephanie, we will kind of throw those at you. So we will moderate those. You don't have to worry about them, but guests, please tell us who you are, where you're joining from, and please put your questions in the comment pane on the right-hand side of your screen. As always, these live streams are hosted by IOCDF. They're live streams that we do in an effort to bring education, content, and connection to our OCD community, which means so much to us. They are not intended to replace therapy. So we encourage you to have your own therapist that you're doing your own individual work with, and instead they're intended to be educational. Of course, IOCDF is not a crisis hotline, and neither are our live streams. So if you're feeling unsafe or suicidal, please call the suicide prevention line here in the US. That's 988. Or, of course, you can follow your own policies and procedures wherever you live for being able to reach your crisis hotline. Stephanie, we are so excited to have you join us today, especially as we go into the new year. I feel like this is a perfect topic. Today, you guys, we are going to bring on Stephanie to talk about, of course, OCD, but to focus a lot on depression. We're going to talk about secondary depression, maybe even primary depression, but when depression and OCD go hand in hand, when they're separate. And one of the big things I really want to make sure we talk about is how do we get motivated and find motivation for OCD treatment when we're feeling depression, those blues, all those things come up. And I say it's a perfect time of year because so many of us have post-holiday blues, but also as we set these 2024 goals, we need to be thinking about how we motivate ourselves, how we encourage ourselves, how we get out of ruts that we might be in. And I think that'd be a great goal for 2024. So Stephanie, welcome. We're so excited to have you. Please spend a little bit of time introducing yourself, telling us kind of your background, what you're interested in talking about today, and what you hope everybody gets out of this live stream.
Well, thanks for inviting me. It's great to see you guys. My name is Stephanie Woodrow. I'm the owner and clinical director of the National Anxiety and OCD Treatment Center in Washington, D.C. I'm heavily involved in ADAA and IOCDF. I present at conferences, I supervise, and love working with patients with OCD and anxiety disorders. I consider myself very lucky to work with this patient population.
Yeah, and I was telling Stephanie, we did a live stream a long time ago. I think it was the beginning of the pandemic about gender identity OCD. I know that's one of the topics, gender identity, for this year's ADAA conference. It's happening in April. So how excited are you to be? You're in Boston, right, this year for the conference?
We are in Boston, and one of the 3 sessions that I'm doing is gender identity OCD from 3 different clinical perspectives. So Dr. Laura Lokers will be talking about ERP, Dr. Lisa Quinn will be talking about ACT, and I'll be talking about ICBT. So really excited to have an opportunity to talk about gender identity OCD, one of my favorite topics.
Yes.
Awesome. Well, we're so excited. So, Chris, I know you had a couple pre-submitted questions. Why don't we start with those and then we'll hop in?
Yeah. So the first pre-submitted question I was kind of talking about before we came on, the number one that we got is a lot of people are experiencing both comorbidity with depression as well as with obsessive compulsive disorder. And a lot of times the big question is, can I find a therapist to treat both? Should I treat both at the same time? Should I treat OCD first, depression first? So let's say somebody watching is experiencing both of those disorders. How do they go about the process of figuring out who to see specifically, but also is there an order that people should be getting support in?
Well, one of the things that I always explain to patients is that as the patients, it's not your job to determine a treatment plan. You absolutely should be involved in the process of coming up with a treatment plan, but it really is the clinician's job to have that clinical knowledge and have that clinical experience and be guiding the process. So, um, that is the responsibility of the clinician. When it comes to determining who to see, if somebody has OCD, it's really critical that they are seeing an OCD specialist. Anybody that specializes in OCD, has experience in OCD, knows how to treat depression as well. Because if somebody has OCD, it is more common than not that they are going to have co-occurring depression. Um, there aren't some great statistics out there, but the closest that we can see is that if somebody has moderate, a minimum of moderate OCD symptoms, then they have a 70% they have a 70% chance of having co-occurring depression. So if you have OCD, more than likely there's going to be co-occurring depression. So first place is make sure you're seeing an OCD specialist.
Yeah, I think the DSM talks about almost like 68 to 70%. So that's 7 in 10 people with OCD are also experiencing depression. When somebody's experiencing depression, does that mean that they can't get better from OCD? I think that's one of the questions people asked as well, is like, is that preventative from being able to get help? Or do we see people getting help, getting better rather, from having both OCD and depression? Like, is there hope?
Absolutely, there is so much hope, and one thing that's important to recognize is the difference between primary depression and secondary depression. So primary depression is when that is the main issue that is going on, and that's when we treat depression directly. If somebody has OCD and what we call secondary depression, that means the depression is the result of the OCD symptoms. And when that's going on, what we really want to do is treat the OCD, because the depression most often is the result of what OCD is doing to our lives. OCD is preventing us from engaging with the people that we want to be doing, enjoying the activities that we want to be doing, and preventing us from, achieving the goals that we have for ourselves. And so when that's going on, of course, you're going to be experiencing depression. So if somebody has co-occurring depression and OCD, we want to work on the OCD first. And the idea is that as the OCD improves, the depression typically will lift as well.
Yeah, Liz, you work at a treatment center, obviously residential, and you see like more severe cases. Do you see that pretty much a majority of people that come in are also experiencing depression, or is that something that you're not seeing as much?
Yeah, 100%. So, as Stephanie was mentioning, I think that we obviously see some patients who have a primary diagnosis of depression and OCD, or depression and maybe OCD secondary, but our typical is that most patients have OCD with a secondary diagnosis of depression. Some of our patients may meet clinical diagnosis for depression, and some have depressive symptoms, but they may not meet the diagnostic criteria. But what we find is that most common than not, patients see their depression decrease as their OCD decreases. And what we also find is that we are CBT specialists, so we know how to treat depression, right? Most of us that treat OCD and anxiety can also treat depression. And so we're doing comorbid treatment approaches. So we might be doing ERP for OCD, but behavioral activation and some specific CBT work to address the depression at the same time. What we find is that depression starts to decrease when people quit avoiding and they start getting out into the world in their life again. And guess what? So does OCD, right? I always tell people the best way to treat OCD, of course, is ERP, but the next best way is also to start to actively make your life louder than your OCD is. And that also is going to help depression, right? If you start to make your life louder than depression.
Absolutely. And I mean, I think the big thing is what we're all looking for in treatment, right? Is to get our clients to get back into the things that they value and back into the things that they love. I want to just ask you again, Stephanie, what's the difference between like Liz, you just talked about like a primary diagnosis of depression versus like secondary depression. How does somebody know which one they have, and what would that look like comparative?
So it's really what is kind of at the forefront, what is dominating. And typically, as Liz said, when somebody has OCD, that's usually going to be dominating. And with the depression symptoms, it's when it's secondary, it's more going to be I'm incredibly distressed and upset about how the OCD is preventing me from living my life the way that I want to. In terms of how they're feeling, though, the depression symptoms can be the exact same. So it can be, feeling extremely tired, having feelings of hopelessness, um, changes in appetite, um, all of the typical depression symptoms. And again, this goes back to making sure that you're seeing a clinician who specializes in OCD and they're able to tell the difference.
Yeah, what are some other signs? You mentioned some, Stephanie. What are some other signs, Liz, that you see in depression? Like one thing that I see a lot of times that we don't always talk about. It's not always in men, but sometimes you see in men a lot of anger. I think sometimes people don't recognize anger as a depression symptom. Sometimes it is, a lot of masking, right? Like feeling very, very fake around people, having to have expectations of being upbeat, but then really feeling drained and tired from putting on an act. So, what are some other things maybe you see when people are experiencing depression?
No, I think that's totally fair. What we know is that agitation is actually a sign, could be a sign and symptom of suicidality as well. And so we want to understand the agitation and what that looks like. But, a lot of symptoms include like this lack of motivation, low energy, not a lot of willingness, all those sort of things. And so again, depression can look so different, but I think there is a stereotype of depression being like people withdraw, people isolate, and that is kind of the norm. It doesn't always have to be. You can be functioning but still feel depressed, especially if you feel like you're trapped in this OCD world. That can feel really depressing. But oftentimes depression is really rooted in like this withdrawal and isolation and lack of energy, lack of motivation, that increased sleep, right? All those sort of things.
I also
And
see like, oh, go on, sorry.
so I just wanted to mention that the withdrawal can also be an internal withdrawal as opposed to an external withdrawal. So we do have some people who staying at home, not interacting with other people, but it can also be people still showing up at work and things like that, but they are internally vacant and they're just I'm going through the motions of it, but I'm not feeling anything. There's no interest in what I'm doing, but externally it looks like they're functioning completely normally.
Yeah, another thing that I see is like a lack of focus. I think sometimes people don't recognize like it's really hard for them to concentrate, really hard for them to focus. And then another one is just a lot of internal negative dialogue. We already see that in OCD. A lot of people, especially if they're dealing with taboo topics, they start to lose like faith in themselves. They start to feel really poor about themselves, stop trusting themselves. They start feeling as if they're kind of like a bad person. But with depression also is just a lot of internal negativity. What's the point? You're not even good at it. Nobody misses you, et cetera. And so it's really, important to kind of know the width of all the different symptoms, because sometimes clients will say, oh, I'm not depressed. And then they'll talk about like, yeah, I'm really finding it hard to sleep. I can't concentrate. I'm snapping at people. I'm angry all the time. And I don't feel like it's my anxiety. And it's like, those are signs of depression as well. We talked a little bit about behavioral activation. So Stephanie and Liz, if you could jump in, what does that look like? Like what, if somebody is experiencing depression, what is the kind of behavioral activation? What is CBT? Like, what does that look like? What should they be looking for if they're getting proper treatment for depression?
So behavioral activation is when we are physically starting to do things. So we're making sure that we're engaging in physical behaviors. So even if we're not feeling motivated to, making sure that we are taking care of our hygiene, brushing our teeth, getting up, getting dressed, going and physically doing activities, even going for a walk around the block, physically getting our bodies moving and making sure that we're eating and just getting ourselves moving, and that helps get the brain moving as well. That also is going to, because it gets the brain moving, it's going to create a little bit more of that motivation to engage in other behaviors.
Yeah. And Liz, what about like the cognitive part? Like, what if somebody is experiencing those really negative thoughts and they're having thoughts about not being worthy or not feeling good enough? Like, what are some of the things? Obviously, if their OCD improves, the depression starts to improve as well. But what are some ways to kind of work through? Obviously, Stephanie talked about the behavioral component, and that's so important, right? People with
Yeah.
depression are typically slowed down. But in addition, what are some other strategies people could be trying?
Yeah, so I mean, of course, there's also medication adjustments that can be made to help with depression, but a lot of what we're going to do is a lot of cognitive work as well. So this could look like cognitive restructuring through a thought challenge worksheet, right? Or maybe we're going to start to really, what I would say, like fight, but right, we're going to really look at what are your cognitive distortions and how do we address them and how do we change them. And so again, it's interesting to talk about this a little bit because sometimes thought challenges can be a bit of reassurance seeking for individuals with OCD. They can turn into a little bit of a ritual at times. And so we don't do as much cognitive work in OCD. We do a lot more of behavioral work because we know that's where the bulk of the outcomes really happen. You can't really think your way out of having OCD. And so with depression, you can't necessarily do that either. But sometimes it is important to say, okay, what are these cognitive distortions? What are the black and white thinking that you're experiencing? What are the ways you jump to conclusions? And how can we kind of have a cognitive approach to break that apart, but then a behavioral approach to start to allow you to really see the difference in action? And so sometimes we'll add some cognitive therapy as well.
And
Yeah.
one of the things, Liz, that you just mentioned that is such an important component in terms of depression with medication, when we're talking about co-occurring depression and OCD and whether depression is primary or secondary, we know that dosing is different for OCD than it is for depression. And so again, having a prescriber who knows what dosing is correct so that if somebody has secondary depression, that they to OCD, that they are getting OCD dosing of medication. And again, that will hopefully also help with the depression as well as the OCD.
That's one of the good things is the medication for depression and OCD are often, used the same. Sometimes people might have an adjunctive, but definitely, like you said, always making sure to see a provider that specifically works with OCD. I think a lot of times in our IOP that I work with, we get a lot of people coming in under medicated. And so we end up connecting them with a psychiatrist, and almost inevitably, as they start to get on that proper dose, they're like, "Oh my God, my mind's kind of a little bit quieter, and I'm noticing I can actually sort of push through and live a different way than I was before because everything felt so heavy and felt so challenging." So, with one thing I wanted to ask about in both of your practices, a lot of times people will come in, obviously, with depression and ask you about medication, cognitive work, behavioral work. What about lifestyle? Do we see that improves or helps depression at all? So, better sleep habits, getting some kind of movement, getting sunlight. Do you see that some of those things can be an adjunct in helping with somebody's just general wellness and depression?
Absolutely. Having a schedule, not, not regimented military style, but having some kind of a schedule. And a session I had earlier today, we were talking about that where I was like, I understand it's winter break, but you know what? We got to set the alarm. Like, let's set the alarm for 9:30. Like, you can still, like, that's still plenty of sleep. Let's talk about, okay, you don't need to be reading a textbook, but you can still be reading something for fun. Let's make sure that you're getting dressed. Let's make sure that you're going for a walk. You don't need to run 5 miles, but take the dog for a walk around the block and get those, get your body moving. So yes, having some type of schedule, making sure that you're, getting nutritious food in your body, you're having a balanced diet, getting a little bit of exercise, and making sure that you're getting enough sleep, but also not too much sleep. It can be very easy to oversleep. Um, and and I often say when you're getting too much sleep, you don't feel rested. It's not like, oh, I've gotten 10 hours. That's not enough. If I just get two more, it's not going to improve. So absolutely environmental changes have an impact.
And you talked about it a little bit before, Liz. Oh, go on. Sorry. And then I have a second
No, go
question.
ahead, go ahead.
I was going to say, you talked about a little bit about getting people back into things that they value. I mean, a lot of the patients that are coming to you are probably housebound or really low functioning because they're very severe. How important for the depression part is it to help them sort of build a lifestyle where they're getting up each day? Or I think of like having a purpose. I think a lot of times people lose their purpose because their purpose is OCD. So as they get better.
It's actually so critical. One of our prerequisites is that people have to lay out their goals for what they want to get back to when they return or finish treatment, because we have found that the individuals who have much poorer outcomes with us are the folks who don't, in fact, have any goals, and they don't really have this purpose and schedule that they're going to return to. And so for us, discharge planning starts week 1, day 1, where from the second you arrive, we're going to start talking about what do you want to return to? What's that going to look like? How do we start building that life? How do we start creating that schedule? And then of course we mimic that here. So in our programming is from 9 to 4. It's kind of from the time you go to school or have a job. Our group program, you have to get dressed, walk across the street to go to the facility and location where we have our groups. And a lot of that is intentional for us. We want to mimic having to get up, have a schedule, get dressed, get ready, not be able to like wander down in your pajamas, but instead you have to be able to really function, right? The way you're going to function when you go home. Part of the other reason is that facilities like ours are built the way we are, where we're residential, not inpatient, is because we want you preparing your own meals on occasion. We want you doing your own laundry. We want you to be able to go off site. We want you to go on community outings, because again, we want that integration back to life to be something that you've already been practicing. But what we know is that if we create this isolated environment where you come and you're in this group environment and you never leave the house, you don't make your new community, you don't make new friends, you don't go out and engage, that also is a recipe for depression to just brew and to continue to be there. And so it's interesting because I always say depression treatment also becomes OCD treatment, because again, part of OCD treatment is less avoidance and engagement, and OCD treatment is less avoidance. Depression treatment is less avoidance and engagement. And so it really tends to address both things in different ways.
And what about if somebody's kind of lost their values? I think we've gotten that when we did that talk on ACT, Liz, about people that are kind of losing, they feel because of their OCD, and in this case, OCD and depression, they've kind of lost their identity. What are some strategies, or what are some ways, Liz, and then Stephanie, I'd love for you to chime in as well, that people can like reconnect with the things that matter? Because I see such a lifting of depression when people found their thing. I after my treatment, I started at an animal shelter, and just going there twice a week like really got me out of my depression. I got a pet dog, and obviously dogs don't cure depression, but heck, it really, really helped. So what are some things, Liz, people can do if they've kind of like lost their mojo, I guess is what I'm trying to ask.
So we have patients do this. We have them volunteer. We have them volunteer at nurseries. We have them volunteer at the homeless shelters. We have them volunteer at the animal shelters, right? But all sorts of places in town that we want you to get out and do stuff to be productive, to feel good, to feel meaningful and purposeful. This is a part of treatment, right? I always talk about a final piece of OCD treatment being advocacy. And I think the reason I push that is because it gives you a purpose. It allows you to feel like something good can come from all the suffering you had to go through for your OCD and anxiety, where you can impact people. You can positively change their life. You can positively change their outcomes. And then it becomes your own accountability tool. And so these are the sort of things that scheduling, staying busy, reintegrating with life, right? That's critical. It's a critical piece of treatment that needs to happen for both OCD and depression.
Yeah, Stephanie, on the outpatient level, what are some things either clinicians can do to help, clients kind of identify getting back into some engagement in life? And then what are some things that clients themselves can do if they're in more like weekly treatment? What are some things that they can try so that they sort of aren't? I always get nervous if my clients are only coming to see me and then they're at home all week, and then coming to see me and home all week. So what are some strategies that either clinicians or people with OCD can utilize?
I think it's really important to have little things that you're excited about. I spend more time talking about Taylor Swift, and I like Taylor Swift, but I spend more time talking about Taylor Swift. And the thing about it is especially, during the heart of the pandemic, this was something that people were getting excited about, and it was motivating. That's great. So let's listen to some music. What can we be excited about? You've just done something really challenging. Great. What's a reward that you get? Afterward, and having that. And I do think it's really important to have, create schedules, again, just a general idea of what you're going to be doing during the day. for people who feel like they've lost their values, okay, you don't need to know that right now. What's something small that you can look forward to? We can help you find your values and rediscover your values. Your values have not disappeared. You are still who you are. OCD and depression are clouding them a little bit. And I often use the example of, your true personality is like the sun, and OCD is the clouds in front of it. The sun has not disappeared just because the clouds are there. We just need to break up the clouds so that the true self can come through and shine again, because you're still there. You are not gone.
I'm so glad you said that. I think a lot of times, whether it's depression or OCD, people think they've like lost something, right? They think they've either lost their mojo, or they've lost their passions, or they've lost something. And I always tell people, I like your analogy of the clouds. I always tell people, like, OCD and depression puts up a blockade. You haven't lost yourself. You haven't lost your abilities, your charisma, your personality, and things like that. The disorders, unfortunately, have dimmed your shine, and that's fine. That's what the treatment is here for. I wanted to pop up another pre-submitted question. Someone asked, how do we break through depression when OCD is equally as bad, and telling me that this is as good as it gets, and I'm okay with the way that I'm managing my OCD, but then I'm depressed because I can't do anything? So how does somebody navigate when OCD is really strong, depression's really strong, the messaging they're getting is kind of like, this is the best that it's going to be, like from the OCD, but then they're depressed because they're like, this can't be the best that I get. It's not very great. So how do people
I want to jump into this one just because, we talk a lot about this, and you can watch some of our previous webinars. The specific ones I would encourage you to watch are freedom, not functioning. But again, my question I always want to ask is, you guys, what are we fighting for? Are we fighting for freedom, where we can live whatever life we want to live and OCD makes no decisions for us? Or are we settling for functioning with OCD? Because many of us with severe OCD, we settled for functioning, or you are right now. But I know I settled for that for many years. And I could function at a high level while still having OCD until my life, my values, my world got bigger, that I couldn't do the things I wanted to do. And that's why I always say, I want you to make your world bigger than OCD. I want you to make your world bigger than depression. Because the bigger we make our world, we're going to have this pull to get to freedom, because we want to do all these great things that are out there, versus if we're just settling with functioning, it's really hard for us to convince ourselves to do this harder stuff because we don't see the need for it, right? Oh, but I can still hold on to 2 hours of rituals because it's no big deal. But guess what? If you're working full time and you meet someone and you want to be in a fulfilling relationship, that 2 hours might feel brutal. And now all of a sudden we really want to reduce it and get rid of it. And so again, this is that piece of make your life louder than OCD, but also fight for freedom and treatment. I think so many people have this thought process, and I know I was there for decades of my life, where I really did believe having OCD meant I'd always have to suffer. Having OCD meant I would always struggle. And the reality is that's not the case. You can have freedom despite this diagnosis, and that's what we're fighting for.
And if somebody is saying, I have OCD, but my OCD is stable, or this is, it's not interfering, but they're still having depressive symptoms. My question is going to be, what is when you're saying that OCD is still existing in your life, how is it existing in your life? So what is going on when OCD is showing up? So, okay, maybe you're still able to go to and spend time with friends, but are you enjoying that experience? Are you present for that experience? And if the answer is no, then the OCD is louder than we want it to be, and it could very easily result in depressive symptoms because you're not enjoying the things that you want to do, and your brain is going, I should be enjoying this because I'm with my friends, so I should be having a good time, but I'm not.
Yeah, those should statements can get you, because people are like, well, I should be this, right? And then people, because they're not feeling that way, there's such that harsh judgment of your experience. I always think about it as like the feedback loop. Kim Quinlan was on, and she was talking about like the second arrow. Like, depression and OCD is already hard enough, and kind of like stabbing your own self by like judging that you're not as happy as other people. I wanted to throw out another pre-submitted question we got is, and I hear this a lot for people with OCD, is like, how do I deal with the depression of feeling behind because of having OCD? It makes me depressed seeing former friends doing better than me. So how do people deal with that depressive feeling that they feel like they've lost part of their life or wasted their life, or they feel a lot of shame or guilt because their life didn't necessarily go the way they had planned pre-diagnosis?
I once had a patient turn around to me and say, "I think I should come up with a 5-year plan. Have you ever made a 5-year plan, Stephanie?" And I said, "Oh my gosh, I've made a lot of them." And she kind of got sullen. I said, "You're missing the follow-up question." And she goes, "What's the follow-up question?" I said, "Has it ever come to fruition?" And she goes, "Has it?" I go, "Not a single time. Never once has it worked out how I've planned." I go, "It's wonderful to have ideas, but that doesn't mean that that's how it's going to happen." So sure, it's great to have goals and things like that, but comparing yourselves to other people just robs you of joy. And we can celebrate what other people are doing and we can be happy for other people, but focusing on what you're doing, your own path is so incredibly important, and being excited for what's going on in your life. And the things that make us happy and joyful and fulfilled can be different than our friends, and that's okay.
Yeah, no, I mean, it's a good point too. I think a lot of people with depression, with OCD, with mental health assume that people without it are just like living this amazing life and everything they plan comes to fruition. But it's remembering that there are a lot of people out there without mental health disorders that make those 5-year plans, right, Stephanie? And then they don't come to fruition. And that's just part of life. Part of life is constant growing and changing and evolving and learning. I'm glad that you mentioned the comparison component, because comparison, I was telling a client this who's really struggling. This was kind of his question. He's like, "Oh, you're doing a live stream about it. Can you ask this question? I want to hear other perspectives." Because yeah, I mean, it's just I was telling him, like, comparison robs you of joy, because you're never comparing. Like, nobody is ever like walking down the street and seeing somebody without a home and saying, "Oh, I'm so glad my life is better than them." Ha ha. Nobody does that, right? Like, we see people that we idolize or people in positions that we want, and we're like, wow, their life must be perfect. Here I'm not. And that comparison just drives the depression up. And then it's harder to do OCD treatment because now you're feeling hopeless and powerless.
And the other part is that when we see other people's successes and we're genuinely happy for them, it actually feels better for us. So when somebody tells me about another group practice owner and a success they have, I'm going, "That's awesome. That's good for our community." Like I want all patients to get better. This is a positive thing. I'm happy about this. I genuinely believe that. I'm not going, "Oh my gosh, this is a terrible thing for me." No, this is a wonderful thing for our community. So that's another thing, when we can look at other people and go, their successes are part of a bigger picture that I do care about.
Absolutely. Liz, I want to ask you the other question. Someone asked, pre-submitted, that we've had for a while, if depression comes from a traumatic loss, and making OCD treatment feel impossible, should I focus on trauma treatment first?
It's a great question. I think that if you're experiencing depression and grief at this level, that it feels like that is what's primary and weighing you down, and that OCD can't even be focused on, you absolutely should address that first. Now, many times you can start to process some of this and jump into OCD treatment at the same time. And so the question I would have is, do you find that there's a lot of OCD rituals around this loss and around this trauma, and does it need to be done at the same time? But otherwise, I think that if you're finding depression, loss, trauma, grief is so loud that it is more loud, so to say, or louder, I guess, goodness, than OCD, then I would do that work first.
Yeah, no,
Yeah, so many
definitely.
great questions, you guys. I love this. I feel like we are really getting to hear from you guys and answer a lot of questions, and you guys have submitted so many live, so we are gonna hop on over to the live questions and go there. So let's start with Charles at 10:34 my time. Good afternoon. I'm currently 3 months into ERP therapy and progressing nicely. Congrats, Charles. It's amazing. How long each day would you recommend doing active exposures? I've read an hour, but would love your opinion. Chris, why don't you take this one?
Yeah. So first of all, congrats, Charles. I'm so glad treatment's doing well. One of the things that I always try to see if I can do with my clients is there a way to incorporate the exposures as part of just everyday functioning? So if I'm working with someone that's really struggling with eating, is there exposures that we can incorporate in their meals? That way there's a guarantee, like 3 times a day. If there's bathroom exposures, can we integrate that in your bathroom routine? And what's great is the people will have that, that time period sort of be checked off automatically. I've read as well, like some of the experts thinking that at least an hour is definitely effective. So I agree with that timeline. I would say, but it's really up to you. Exposures don't have to be torture. They don't have to be difficult. I think sometimes people are like, I can only do an hour, but are there ways that you can incorporate into functioning? If you have some contamination around your pet, can you get some extra exposures by taking your dog to the dog park, by washing your dog, by walking your dog? So what I would say is, yes, having some set aside time is definitely a key, but how can you incorporate it into every part of your daily functioning? So for me, for instance, like one of my fears was leaving out drinks because I thought people might mess with it, etc. So I would deliberately like go to a restaurant and then go to the restroom 3 times and kind of leave my drink out there. I had to eat anyway, so might as well get some exposures in. So I would say you're solid with at least an hour. I would definitely agree that's a good timeline. But remember, the more effort you put in, the quicker you're going to get better, right? So if there's an opportunity, like I said, throw it into other aspects, that's going to be definitely impactful and effective.
And I want to echo, I'm so glad that you're getting benefit, Charles. But and you're talking about exposure, which is obviously important, but to me, the more important part is the response prevention. So yes, you can be doing intentional exposures for an hour a day, and that's typically the number that we say, but you can spend a lot more time doing response prevention and making sure that you're not engaging in those compulsions, and that that can be a constant, and that's really tough. It is absolutely tough, but that can be something that you're consistently working on.
Good
Yeah, I
point.
always tell people I actually don't set recommended amount of time because my answer is I want you living your life, which means you're going to be doing exposures. I care more about, are you no longer avoiding, and are you no longer ritualizing, and are you living your life? Because if you're choosing to go do something that's meaningful and it has a built-in exposure, that's actually going to have so much more value and weight on your outcomes than if you sit and write a list of exposures you're supposed to do and sit down and do them. Okay, love that. Great question, and congrats on treatment already being successful. That's amazing. Jen, I read this earlier and it just warmed my heart, but no question, but so proud to say that on December 27th, I celebrated a year from the day I decided to take my life, and a year later would consider myself in OCD remission. Yeah, nothing I can say except this is what it's all about. Love this.
Yeah, that's amazing. I mean, I love hearing stories like that. And Jen, thank you. I mean, I think of these live streams, I think of our guests, I think of Liz and stuff. We're trying to really build this community. So sharing success stories like that is going to give other people hope. It's a form of advocacy, and we really, really appreciate your comment.
Congratulations. It's a difficult journey, and I'm so glad that you've taken that journey and that you're at the place that you're at.
I agree. It's always good to hear stuff like
Sorry,
that.
guys, I keep having to blow my nose. That's why allergies got me this week. But from S. Emanuel at 1111, does too much daydreaming and staring at nothing, is that OCD? And is there a treatment option for this? Chris, do you want to take it?
Yeah, so there's a good a friend of the community, Kevin Foss, has a podcast called the Fear Cast, and he actually did an episode on what people have started to kind of call this this concept of maladaptive daydreaming, and I think it's a really good listen. So first of all, I'd say Emmanuel, definitely check that out. It's called Fear Cast. Kevin Foss, and the episode is about maladaptive daydreaming. What we know about the brain is the components that impact OCD also impact imagination. There's a lot of components where, when you have a hyperactive amygdala, we also have this like very vivid imagination. And so I see in a lot of clients, especially if they don't have a lot of structure in their life, or if they're kind of living a lifestyle that they're not happy about yet because they're really under the throes of OCD, a lot of that daydreaming. What I always tell people is daydreaming isn't a negative thing. It's not a bad thing inherently. It comes down to how is it impacting your life. And the reason we came up, the kind of like the community, there's not really a DSM diagnosis of maladaptive daydreaming, is because I've had clients where they'll lay in bed for 5 hours and not really get up. And even if it is positive things and exciting things, it's not always kind of effective. I always say, first of all, make sure just to kind of rule out ADHD. We see that a lot in ADHD is kind of just like a lot of kind of like in our head, daydreaming imagination. But there's a lot of clients that do it, but don't have ADHD. And like I said, typically it's like they don't have a lot of structure. They have that free time to sort of daydream. So what I would say for you is if there is too much daydreaming, if it's kind of going on throughout the day and you're not really finding yourself getting things done, that's when you want to get an intervention. So one thing that I've seen that really helps with my clients, they talk about it in the podcast, is noticing like what is sort of the setup before it comes. And then are you recognizing you're doing it? And if you are you able to kind of get yourself out of it and re-engage in something? But having structure, having things to do, having things that are taking up your attention is definitely going to be most important. But definitely check to see if there's an ADHD diagnosis, and make sure it's also not rumination. Make sure you're not thinking it's daydreaming, but really you're imagining things. Because sometimes clients will say, oh, I just daydream. And I'm like, what are you daydreaming about? Oh, that everything in my house is clean and I don't have to struggle anymore. I'm like, that's a little bit more OCD based than just kind of fun daydreaming. So
And following up on that, making sure that the daydreaming is an avoidance. So I don't want to deal with what I'm going to have to deal with if I leave my bedroom. So I'm going to daydream about being on a beach somewhere. It's great to daydream about being on a beach somewhere, but not if you're not actually living your life, and not if you're not functioning in your life the way that you want or need to.
very good point. I'll throw a pre-submitted one, then we could go back to you live, Liz. Somebody pre-submitted, it's a pretty heavy question, but will I have OCD for the rest of my life?
It depends what you consider OCD. So I will tell you that we are genetically made up to have OCD in the sense that we're predisposed to it, right? We may find that we are more likely for thoughts to be a little bit stickier than people without OCD. But with effective treatment, you can have freedom from your illness. And so you can get to a place where you don't even meet diagnostic criteria anymore for OCD. So I would say, like, no, you don't have to have OCD in the sense that it doesn't have to be a disorder that's disturbing and disruptive in your life anymore. And that's really what we're fighting for. And that's our goal. That's our goal in treatment.
Yeah, and there is some research that's been done about the difference between uh, being in remission, like the technical terms of being in remission, or recovered and things like that. Ultimately, I'm asking somebody, how is it affecting your life, or is it affecting your life? Do we really need the actual term? And most people, if they're getting to live their life, they don't really care about whether it's a technicality or not.
Yeah. And I would say too, how I always answer the question is like, is the majority, if not all of your decisions that you're making on a daily basis based out of values, or is it OCD? And that's how you can kind of see remission. But I always like to put the caveat is it can be scary sometimes to hear the word chronic, but I promise you, I mean, Liz and I can speak to it, having OCD as well. And Stephanie, I mean, you probably see it with all your clients. There's a huge difference when somebody leaves treatment and is doing really, really well. And nobody ever regrets going through treatment just because the term chronic. But for a lot of people, like as they get into a better place, they definitely are happy that they did it, right? Going from like 100% of your life to maybe 2% is a huge difference. So don't get overwhelmed by the whole chronic term. I think people get scared by it.
I actually don't use I never use the term chronic just because it sounds terrible. What I
Sounds
will
scary, huh?
do, it sounds awful. And just like I don't use the term comorbid, I say co-occurring just because it sounds awful. And so what I'll say is you are vulnerable to it. So yes, I'll have former patients come back and they go, I need a buffer. I need to tune up a little bit. And I'm going, absolutely, let's do a few sessions, let's get you back on track. I think most people but they're not getting back to where they were at their worst. And so if you're going, yeah, I need a little, I need a little bit of a boost. That's still a heck of a lot better than where they were before treatment. And most people are absolutely willing to be in that place. So again, the technicalities can matter in terms of research or in terms of the clinical work, but we care about functioning and what does your life actually look like?
Really well said.
That's right. Couldn't have said it better. So many great questions and lots of you guys. I love how much y'all support each other. So we'll go to Yvonne at 11:12 my time, Brennan. Hi, a question. How do you treat contamination OCD with something you'd consider dangerous? You come into contact every day. How would this be treated, please? So Chris, maybe you could share this, since I know some of your OCD was around something that, like, there is a little bit of a risk of like certain chemicals and certain things. And so can you share a little bit about how to differentiate danger versus OCD perceived danger?
Yeah, what I always like to do is slow it down with clients and ask, like, my big question I always ask clients is kind of like, how did we get here? So this was very much my OCD and getting to a point where, sure, I mean, Yvonne, there are things out there, contaminants. Like, I was very afraid of bug spray. I was very afraid of like houses getting tented. I was afraid of, driving by in where I live in Orange County. If you drive up PCH, there's power plants and you see the smog in the air right near the, Huntington Beach. And so what happens is with OCD, we are such black and white thinkers. Either something is safe or something's going to kill us. There is no in between. There's no nuance, right? And so that's one of the things I teach my clients. I see with contamination, especially pretty severe, people have reinvented how contamination works in their head when them and OCD kind of have come together. And so we have to really look at is like, how did you get to a point where things have become such black or white extremes? My guess is no. I mean, if there is some toxic waste or something, no therapist in their right mind is going to say, well, Yvonne, you have to learn how to swim in it and be okay with it. So my question would be, you say you come into contact with it. Is it maybe an old building with asbestos? Could it be, you have a lot of bugs, your parents are spraying? What I always tell people is there's middle for a reason. There's gray, there's nuance. So how are people that you trust and care about around you handling the same situation? Why does OCD give you an extra set of rules that has you have to treat it differently? And that's when people with OCD will start coming up with things like, well, I'm really sensitive to this. This bothers me a lot more than the average person. So it's a little hard to answer this question just because I don't know what it is per se. But if it's the things that I was afraid of, what I learned to do is like, sure, there's products out there that are green bug killers if I really need it. But at the end of the day, there's instructions on the bottle. If you follow them, you'll be fine, but with OCD, we get into these extremes of like pure avoidance of things. And so that's when I see people trying to figure out what year a building was built before they're willing to go in because they might get asbestos. There's a difference between being up in the ceiling, ripping open asbestos, and being somebody who visits a bank that's older. So I would really say it's like working with a clinician of coming up with that more balanced gray understanding so that you can start living your life, because unfortunately there's going to be contaminants around you every day, all day. We got to learn to live with them versus living complete avoidance without them.
But I think part of that idea of contamination is also the idea of, if you're talking about a bottle, a can of bug spray, the can of bug spray is not the problem. And even if you get a little bit on your hands, that's not a problem. What somebody is actually worrying about is, oh, I'm going to consume this. These are all different degrees of contamination, and what actually is normal and what actually is reasonable and what is completely in the imagination. So if I go to the gas station and I'm pumping gas, it's not unreasonable that I'm going to get a little bit of gasoline on my hands, but that is not the same contamination or danger level as if I'm drinking gasoline. And so we need to recognize that these are different degrees and there are different risks, and what actually is a risk versus what is the imagination of a risk.
Yeah, and again, what I want to remind people is that there's a huge, huge, huge difference in what we perceive to be, which someone, I should say, without OCD might perceive to be gross. Like my sister will always say, oh yeah, I think getting gas is gross, right? A lot of people think that's gross, or like that's not the most clean thing that you could do. But there's a big difference in something feeling gross versus OCD telling you it's dangerous, it's risky, it could impact your life, right? And so we have to, sometimes I'm gonna have to go do stuff that feels gross and that even someone without OCD might feel is gross, but they'd be willing to do it, versus individuals with OCD who have these hard lines, right? And so a great example of this is during COVID. CDC gave guidelines, right? And you could use those guidelines as a rubric for, okay, I'm gonna do a 20-second hand wash, or I'm gonna keep 6 feet, or whatever the guidelines were that made sense and that you agreed made sense for you to keep yourself safe. But someone with OCD wasn't able, if their OCD was triggered around COVID, they didn't stop at a 20-second hand wash. They didn't think 6 feet was enough, right? You took it to more degrees, to more degrees, to more degrees, and it became this never-ending cycle of how do I stay safe? And so again, I always say we want to take recommendations, doctors, whoever give them to us, and we follow their guidelines, not OCD's guidelines.
And I'll typically work with a patient and I'll say, we can pick three authorities. So, FDA, NIH, CDC, Mayo Clinic, things like that, where we're picking a couple of those. We are not hunting around to find somebody that confirms. And one of the options is never read it. Reddit is never an option as an authority on anything. So, we pick usually 2 or 3 options of these are the official, sources of information that we are going to, and that's it.
Yeah, I was talking with Dr. Patrick McGrath. We're like, as OCD therapists, if we could eradicate Reddit off the face of the earth, because everybody's like, but I read this on Reddit. I had a client that was like, I can't use any soap with this ingredient in it because I saw somebody on Reddit say it actually doesn't clean you. Meanwhile, it's found in like 99% of soaps. And so now they're searching the internet. And it's just like, but that's not even an authority. So that's something that I always talk to clients about, confirmation bias. It's like we think we're going in with this kind of clear, conscious sort of like, I'm just going to kind of look around and make a decision based on what I find. No, what we're really doing with OCD is we're sort of kind of bypassing anything that may give us go against the OCD. And we're searching for something that will confirm what OCD has already told us. And then we're like, see, this is why my compulsions make sense. And that's what keep the compulsions, valid, and we want to get rid of them.
If you want to know if purple monkeys exist that only eat green bananas and not yellow bananas, I guarantee you somebody on Reddit has one as a pet.
Right,
It's
exactly.
wild. So wild. Oh man. Okay, from Kelly Rubin at 11:14. Thoughts if I'm stable on a 2 max dose medications for depression and OCD, which would be destabilizing to change, but I still have a lot of depression and anxiety. I'm working on additional comorbidities. Is that key? Stephanie, why don't you take this one?
So, I'm somebody that is very passionate about psychopharmacology, but I always start off by saying I am not a doctor and I don't play one on TV. So I'm not a prescriber. When you're on 2 medications and you're on the max dosage, the question is there might be a possibility that you might need an additional medication. That is a possibility. I think the idea with medication is that it's allowing us to engage in the therapy and making sure that you're doing evidence-based therapy with a trained clinician who does specialize in OCD. So making sure that that is a huge component and seeing what effect is that having and what things are you not able to do in your life right now and what changes can be made in that sense of it. So kind of doing an overall, you know, um, assessment in some ways of what's happening, what's not happening. What am I getting to? What am I not getting to? So medication is a wonderful component of treatment. I am a huge advocate of medication, but it is not the exclusive answer by any means.
Exactly. Um,
Good.
and what I will say is that, yeah, it's medications do help us, right? But behavioral therapy kind of gets you over the hump, and so we really wanted to be doing both. And so if you find that the medications are working and you don't want to change them, like no need to change them unless your psychiatrist thinks you should, but you should change other approaches, as Stephanie's saying. Okay, want to keep going to get our next question. And there's a couple medication questions. We will move those into our medication talks where we have a psychiatrist on board. None of us are equipped to handle any specifics around dosage and type of medication and that sort of thing. So this, I want to go to the next person, Lisa at 11:24. Does residential program make kids more depressed from being away from their home and families? How do you know if it's the right choice? This is such a good question, and I'll take it first, and then y'all can jump in. But I get this question all the time, and I get this question from adults that are parents that are like, well, how do I leave my kids and go do treatment? And my answer is typically like, you're usually seeking out this level of care because you're not really even engaging with your kids that much because of your anxiety and OCD. And so this program is going to get you to re-engage. So yes, the break feels really difficult, but think about the time it's going to give you in the future. And I would say the same for kids. However, if your child doesn't necessarily need a residential level of care, a lot of parents will look into PHPs. And I think they're a great option for family members and parents because what we know is that you really can't treat the child in isolation. So unless your child really needs a residential, I would consider a PHP program where you can be an active part of it. And I would look for one that actively engages in parent coaching, that the parents are being brought into treatment, and that you're learning the tools as a parent on how to continue that treatment when you return back home with your kid. You can't send a kid with OCD away to get treatment and have them come back to the same old system and environment without changes and think that the outcomes are going to stick, right? The whole system has to change. And so if there's an opportunity to do treatment as a family, I think that's the better approach if you ask me. But if your child needs residential, they treat depression, they treat OCD. It should be their job to be able to make sure that it's not going to make it worse, but instead it's going to make it better. But this is a common question. But at the end of the day, the bigger chance of depression and OCD getting worse is if it's left untreated, not if it's effectively treated.
What I just want to add is I know for me, any client that I've sent to residential that are under 18, like minors, they make so many friends. That's the thing I just always think of is like they come back, they met a lot of people that they really clicked with. The parents are often coming out there to visit or maybe FaceTiming or doing other things. But a lot of times the kids have made friends and they just feel really, really positive about the progress that they've made. So I haven't had in clinical practice, I mean, this isn't, a research study, but I haven't had clients come back and be like, that was so bad. I missed my family. If anything, they're better connected with their family now that the OCD isn't causing so much distress.
Next question. Someone asked what residential program I'm affiliated with. Brendan put that in the chat. I think I want us to talk a little bit about this, but Mr. J at 1126 said, I in general think ERP is the pink dream, an illusion of psychologists thinking we can just click a button and like our OCD thoughts. It's not like that for me. So I'm thinking what is being said here is like some people think ERP is just like, okay, you just do it and all of a sudden it's better. And so I want us to talk a little bit about this because I think this is really important. And that if people think that, of course, you're not going to be willing to do ERP because you're going to feel like, well, if I could just click a button and just not do these things, I would have done that on my own. I don't need to go to treatment to do that. So Chris, Stephanie, any thoughts there?
Well, I think, first of all, any OCD specialist should be somebody that is really very compassionate about it and is very understanding about what treatment actually looks like. And if you're getting the impression that your therapist thinks that doing any type of treatment for OCD is easy, you need to talk to the therapist or find another therapist because any OCD specialist knows treatment is not easy by any means. ERP is a wonderful, fantastic, extremely effective treatment, but there are other treatments that are options that are evidence-based treatments for OCD. And so, ERP is not for everybody. It's a fantastic option, but there are other options as well. So, if people are not willing to engage in ERP, there are other evidence-based treatments. So, it's not the only option.
What I want to add is I think what I saw in that comment too was this idea of like, pressing a button. I think if I read it correctly, like pressing a button and have us like our OCD thoughts. One thing that I was thinking about is I remember reading a statistic somewhere that I think there's like 2,000 people trained in like OCD treatment in the United States. That's not a lot, first of all. But second of all, I would say the difference between somebody who's trained and then somebody who's actively, consistently treating a full caseload of OCD, going to conferences, reading the research is very different. I was trained in how to work trauma. I was trained in how to treat couples, but I wouldn't say I'm an expert in it. And I don't continue to treat those populations. So I wouldn't say that I would be one of the 3,000 people trained in that modality. So if there's a therapist that you're working with that is trying to get you to like your OCD thoughts, that's why I think a lot of times people simplify ERP and think that it's just like, okay, I'm just going to throw something at a client that they don't like and have them learn to like it. And it is such a more there's such more of an art to ERP than I think people give it credit. It can seem pretty basic, but I do think that really understanding it and learning it, I think there needs to be a cognitive component. There needs to be response prevention. We need to look at core fears. We need to build that rapport. We need to throw ACT in there. We need some motivational interviewing. Like it's a very complex treatment that sounds easy. And so a lot of times we did this talk, Liz, a year ago or 2 years ago at this point about, therapists should not be getting you to accept that you're a pedophile or liking that you're having thoughts about hurting your kid. What you're recognizing is the very component of OCD, the obsessional component, is that you're going to have these thoughts that pop up. Maybe they're triggered for something that's happening around you. You saw something on TV, you interacted with someone. Sometimes it can show up in the form of like intrusive images or urges. And the problem is we misread that and we assume, we kind of build stories around it. And we assume like we like like it, or we want this, etc. And a therapist is actually teaching you to change your relationship with your thoughts and your feelings, and to change behaviors and live a lifestyle that with response prevention and putting yourself in values-based situations to kind of gain yourself. So a lot of times when I hear horror stories about ERP, it's typically not somebody that I even know in our industry. And it's usually things like that. Well, you need to be in the same room as your cousin who you think you want to hurt. You need to learn how to like that thought and become used to that thought, and not, care that you're having the thought. And that's not going to work. It's much more nuanced than that. It's much more of a science. And I think that that's what I'd say, Mr. J, is maybe finding somebody that really eats and breathes and sleeps this treatment, so that you can work with somebody that's not going to put you in a situation that sounds a little bit amateurist, if I was guessing based on the idea of liking our OCD thoughts.
Exactly. Yeah. And it's much more about, can we live our values despite our thoughts maybe being there, than about, can we go purposely think of these horrible thoughts? So this has been so great. And I feel like we've spent so much time talking about depression, OCD, and the comorbidities. And as you can see, there's tons of questions. Chris, you're getting comments that your hair is on fire today. It looks great. So I love that. So, just wanted to share that to kind of get y'all going for your Wednesday at noon. But we love you guys. I'm so excited to be back. We are so excited for the content that's going to come in 2024. Please, of course, always visit iocdf.org/peace of mind, where you're going to find a schedule of all of our upcoming live streams. You can submit and post comments around live streams and content that you want and that you hope we address. And so please be sure to do that. Stephanie, thank you so much for your time, your expertise, and sharing your personal and professional knowledge. It has been so helpful today.
Thanks for having me. I really appreciate it.
Real quick, Stephanie, where can people find you? And then if people want to learn more about the ADAA and your upcoming conference, where can people find about that as well?
So my practice is nationalanxietyocd.com. And if people want to learn more about the ADAA conference, you can go to adaa.org.
Yes, their conference is the second weekend in April. So make sure you check it out in Boston if you can make it, if you're a clinician. And thank you so much for having us on, Stephanie. I really, really hope people rewatch this, especially send this to a friend if they're dealing with depression. I felt like there was a lot of really good information. We loved having you on. You're our first guest of the year, Stephanie. Thank you for coming out and hanging with us on 2024. Hope to have you back. And yeah, Liz, it's a new year. Woo woo.
New year, new you. I see what happened. Oh my gosh, we cannot sign off yet. Guys, your goal is to start setting your intentions and your goals for what you want, how you want your relationship with OCD and anxiety to change in 2024. But more importantly, what I want you to focus on is, I want you to come the next time Chris and I have a lunch and learn with just us. We're going to dive into this, but I want you guys to show up with ways that your life is going to get louder. So instead of saying, I want to reduce hand washing, I want you to say, I can't wait to go eat at this restaurant I've been avoiding. I can't wait to finally go on a date that I really have wanted to go on, right? So I want you to set goals that are life goals for 2024. And we're going to start there. And then we're going to start to say, okay, what OCD do we need to address to make that life goal possible? So don't forget, that's your homework. We're going to start giving you guys homework in 2024. You're going to think that's weird, but I promise we're going to have fun with it. And we will address it in the comment section. We're going to do what we can to make these live streams more interactive and pull your work and comments right into the videos. So do that work. We'll see y'all next time.
Liz, you're giving homework as if you're a CBT therapist or something.
Not like that's what I do for a living. Thanks, y'all. Love you guys. See you soon.
Take care, everyone.